Welcome to today's session on Chlamydia trachomatis, one of the most common bacterial sexually transmitted infections worldwide. We have a 22-year-old man with a history of multiple sexual partners who presents with dysuria and a persistent watery urethral discharge for the past 48 hours. Notice the key word here, watery discharge. This is quite different from the thick, purulent discharge we see with gonorrhea. This watery or mucoid discharge is characteristic of chlamydial urethritis. Now here's the critical diagnostic clue in this case. When the laboratory performed a gram stain of the urethral discharge, they observed abundant white blood cells but no organisms. This finding is highly suggestive of chlamydial infection. Let me explain why this is so important. In gonorrhea, which we've already studied, the gram stain shows intracellular gram-negative diplococci within the white blood cells. But Chlamydia trachomatis cannot be visualized on gram stain. This is because chlamydia are obligate intracellular organisms, with a unique cell wall structure that doesn't stain well with gram stain, and they're extremely small. So when we see white blood cells indicating inflammation and infection, but no bacteria visible on gram stain, we should immediately think of chlamydia. This clinical presentation, dysuria with watery discharge, and a gram stain showing white blood cells but no organisms, is sometimes called non-gonococcal urethritis, and Chlamydia trachomatis is the most common cause, accounting for about 30 to 50% of these cases. As we progress through this session, we'll explore why chlamydia is so different from typical bacteria, how it causes disease, and most importantly, how we diagnose and treat it effectively. Chlamydia trachomatis is a fascinating organism that occupies a unique position between bacteria and viruses. Chlamydia champigoniae are obligate intracellular parasites, meaning they absolutely must live inside host cells to survive and reproduce. They cannot generate their own energy and are completely dependent on the host cell for adenosine triphosphate. This is why we call them energy parasites. They essentially steal ATP from the host cell to power their own metabolic processes. This energy parasitism is the fundamental reason they cannot be grown on artificial culture media like most bacteria. Historically, chlamydia were actually considered viruses, rather than bacteria. This confusion arose because they're small enough to pass through 0.45 micrometer filters, which was a criterion used to distinguish viruses from bacteria. Additionally, like viruses, they're obligate intracellular parasites. However, we now definitively classify them as bacteria for several important reasons. First, they possess both inner and outer membranes similar to gram-negative bacteria. This cell envelope structure is distinctly bacterial, though the outer membrane has some unusual features we'll discuss shortly. Second, they contain both DNA and RNA, unlike viruses which typically contain only one type of nucleic acid. Having both DNA and RNA allows them to store genetic information and carry out protein synthesis independently. Third, chlamydia possess prokaryotic ribosomes, specifically 70S ribosomes characteristic of bacteria, not the 80S ribosomes found in eukaryotic cells. Fourth, they can synthesize their own proteins, nucleic acids, and lipids. While they depend on the host for energy, they have the enzymatic machinery to manufacture their own structural components and molecules. Finally, and very importantly for clinical medicine, chlamydia are susceptible to numerous antibacterial antibiotics. This would not be the case if they were viruses. Antibiotics that inhibit bacterial protein synthesis or cell wall formation can effectively treat chlamydial infections, though the drugs must be able to penetrate into cells where the organisms reside. Chlamydia have a unique developmental cycle involving two distinct morphological forms, which we'll discuss in detail on the next slide. For now, understand that they exist as elementary bodies, which are the metabolically inactive but infectious forms, and reticulate bodies, which are the metabolically active but non-infectious forms. This biphasic life cycle is unlike any other bacteria and is central to understanding chlamydial pathogenesis. The chlamydial cell wall is quite unusual and deserves special attention. It contains lipopolysaccharide, or LPS, which is characteristic of gram-negative bacteria. However, the LPS of chlamydia has much weaker endotoxin activity compared to the LPS of other gram-negative organisms, like Escherichia coli or Neisseria gonorrhoeae. This means chlamydial infections typically cause less acute systemic inflammation than infections with other gram-negative bacteria. The inflammation tends to be more chronic and progressive, which actually contributes to the long-term complications we see, particularly in women with untreated infections. The most important component of the chlamydial cell wall is the major outer membrane protein, or MOMP. This protein serves as the primary structural component of the outer membrane. MOMP is fascinating because it's unique for each chlamydial species, and even among different strains or serovars of the same species. This variation in MOMP structure forms the basis for serological classification of chlamydia. For Chlamydia trachomatis specifically, different serovars are associated with different disease manifestations. Serovars A through C cause trachoma, a chronic eye infection that's a leading cause of preventable blindness in developing countries. Serovars D through K, which are what we're focusing on today, cause urogenital infections and conjunctivitis. Serovars L1, L2, and L3 cause lymphogranuloma venereum, a more invasive sexually transmitted infection with different clinical characteristics. Understanding MOMP is also important because it's a target for the immune response and has been investigated as a potential vaccine candidate, though no successful vaccine has been developed yet. The fact that MOMP varies between strains presents both opportunities and challenges for vaccine development. The developmental cycle of Chlamydia trachomatis is absolutely unique among bacteria and is essential to understanding how this organism causes disease. The cycle begins with the elementary body, or EB. The elementary body is the infectious form of chlamydia. It's the form that exists outside cells and can be transmitted between hosts. Elementary bodies have rigid cell wall that protects them in the extracellular environment, but it also means they're metabolically inactive. Think of the elementary body as a spore-like structure designed for survival and transmission, not for reproduction. When an elementary body contacts a susceptible host cell, it attaches to the cell surface. The EB then stimulates its own uptake by the host cell through receptor-mediated endocytosis. Essentially, the chlamydia tricks the cell into engulfing it. Once inside the cell, the elementary body is contained within a membrane-bound vacuole called an inclusion. Remarkably, chlamydia have evolved mechanisms to prevent the inclusion from fusing with lysosomes, which would normally destroy the internalized bacteria. This allows the chlamydia to create a safe intracellular niche where it can survive and replicate. Within the inclusion, the EB undergoes a transformation. Over the course of several hours, it reorganizes its structure and becomes a reticulate body, or RB, which is larger and has a more fragile cell wall. Unlike the elementary body, the reticulate body is metabolically active. It can synthesize proteins and nucleic acids using energy and building blocks stolen from the host cell. However, reticulate bodies are non-infectious and cannot survive outside the cell. The reticulate bodies then begin dividing by binary fission, just like typical bacteria. They multiply within the inclusion, and the inclusion grows larger as it fills with reticulate bodies. This multiplication phase typically lasts 18 to 24 hours. After sufficient multiplication, some reticulate bodies begin transforming back into elementary bodies. This process is called secondary differentiation. The newly formed elementary bodies accumulate within the inclusion. Eventually, typically 48 to 72 hours after initial infection, the host cell ruptures or the elementary bodies are released through exocytosis. These released elementary bodies can then infect new cells, continuing the cycle. This entire cycle, from elementary body attachment to release of new elementary bodies, takes about 2 to 3 days. Now let's explore how Chlamydia trachomatis serotypes D through K cause urogenital infections. The infection begins when chlamydia gain access to the genital tract during sexual intercourse. The organisms enter through minute abrasions or microscopic lacerations on the mucosal surface. These tiny breaks in the epithelial barrier, which may not be clinically apparent, occur commonly during sexual activity. The metabolically inert elementary bodies attach to the exposed epithelial cells and stimulate their own uptake. Chlamydia EB targets specific receptors on non-ciliated columnar, cuboidal, and transitional epithelial cells. In men, the primary target is the urethra. In women, chlamydia infect the endocervix, and from there can ascend to infect the endometrium and fallopian tubes. Both men and women can develop infection of the rectum if exposed through receptive anal intercourse. Once inside the host cells, reticulate bodies multiply within the inclusion, and this intracellular multiplication continues for 2 to 3 days. Eventually, the host cell is destroyed, either by direct lysis or through apoptosis triggered by the infection. When the cell ruptures, it releases both new infectious elementary bodies and cellular contents. This cell destruction and the release of bacterial components trigger an intense inflammatory response. The host cells release pro-inflammatory cytokines, particularly interleukin-8 and TNF-alpha. The accumulation of these inflammatory cells at the site of infection results in the clinical manifestations we observe, such as urethritis in men and cervicitis in women. There's direct destruction of epithelial cells during the replication cycle. This causes tissue damage and disrupts the normal epithelial barrier. Also, there's the pro-inflammatory cytokine response, stimulated by the infection. This immune response, while attempting to clear the infection, actually causes much of the symptomatic disease, and, in cases of chronic infection, leads to scarring and long-term complications. In women particularly, repeated or persistent infection can lead to chronic inflammation and scarring of the fallopian tubes, resulting in pelvic inflammatory disease, ectopic pregnancy, and infertility. In men, chronic infection can lead to epididymitis and potentially affect fertility, though this is less common than the complications seen in women. For urogenital chlamydial infections, we can use several types of specimens. In men with urethritis, we can collect urethral discharge directly, though this requires inserting a swab into the urethra, which is uncomfortable for the patient. A much more patient-friendly option is collecting a first morning urine specimen. Chlamydia trachomatis is shed into urine, particularly in the first void urine, which makes this an excellent non-invasive specimen type, especially when using molecular diagnostic methods. In women, we can collect cervical discharge or use an endocervical swab. The endocervical swab is obtained by inserting a speculum, visualizing the cervix, and carefully swabbing the endocervical canal, where the columnar epithelial cells that chlamydia preferentially infects are located. Women can also provide vaginal swabs, and interestingly, self-collected vaginal swabs have been shown to perform well with molecular tests, improving patient acceptance and facilitating screening programs. Once we have appropriate specimens, Chlamydia trachomatis infection can be diagnosed through several approaches, each with its own advantages and limitations. We can make the diagnosis based on cytologic findings, looking for characteristic cellular changes or inclusions. Serologic testing can detect antibodies to chlamydia in the patient's serum, though this has significant limitations for acute diagnosis. Culture, growing the organism in cell culture, was historically considered the gold standard, but is rarely performed now due to technical complexity and lower sensitivity compared to newer methods. More commonly today, we use methods that directly detect the organism or its components in clinical specimens. Antigen detection methods look for chlamydial antigens, typically using immunofluorescence or enzyme immunoassays. These methods are more rapid than culture, but less sensitive than molecular tests. The current gold standard and most widely used approach is nucleic acid-based testing. These molecular methods detect chlamydial DNA or RNA in specimens, and offer the best combination of sensitivity, specificity, and practical utility. We'll explore each of these diagnostic approaches in more detail on the following slides. Direct detection of Chlamydia trachomatis in clinical specimens involves staining clinical specimens and looking for characteristic features under the microscope. Several staining methods can be used. Giemsa stain, a Romanowski-type stain used for many microbiological and hematological applications, can reveal chlamydial inclusions within infected cells. These inclusions appear as cytoplasmic structures containing the developing chlamydia. Iodine stain is another option. Chlamydial inclusions contain glycogen, which stains brown with iodine. This property is unique to Chlamydia trachomatis and doesn't occur with other chlamydial species. However, the most sensitive cytologic method is immunofluorescence. In this technique, we apply fluorescein-conjugated antibodies specific for chlamydial antigens to the clinical specimen. If chlamydia are present, the antibodies bind to them, and when we examine the specimen under a fluorescence microscope with appropriate filters, the chlamydia appear as bright apple-green fluorescent particles against a dark background. This direct fluorescent antibody test, or DFA, allows us to specifically identify chlamydia, even when they're present in small numbers. Cytologic examination has important limitations. It requires skilled microscopists, who can recognize the characteristic inclusions, or fluorescent patterns. The sensitivity is relatively low, particularly for asymptomatic infections, where bacterial loads may be minimal. For these reasons, cytologic examination has largely been replaced by more sensitive methods in most clinical laboratories. Antigen detection methods represent another approach to diagnosis. EIAs are more convenient than immunofluorescence because they can be automated and don't require fluorescence microscopy. However, they're generally less sensitive than molecular methods and can occasionally give false positive results due to cross-reactivity with other bacteria. Both direct examination and antigen detection methods have been largely superseded by nucleic acid amplification tests in most clinical settings, though they may still be used in resource-limited settings or when molecular testing is unavailable. Nucleic acid amplification tests, or NAATs, are now considered the test of choice for diagnosing chlamydial infections. Major advantage is that many NAAT platforms can simultaneously test for both Chlamydia trachomatis and Neisseria gonorrhoeae from a single specimen. Since co-infection with these two organisms is common, this dual testing is extremely valuable clinically. Culture, specifically cell culture, was historically considered the most specific method for diagnosing chlamydial infections. Because chlamydia are obligate intracellular parasites, they cannot be grown on artificial media, but must be cultivated in living cells. The clinical specimen is inoculated onto a monolayer of susceptible cells, typically McCoy cells or HeLa cells, and after incubation, the cells are stained to detect chlamydial inclusions. While culture is highly specific when positive, it's relatively insensitive compared to NAATs. The organism must be viable, specimens must be transported properly in special media, and the procedure is technically demanding and time-consuming, typically requiring 48 to 72 hours or longer. For these reasons, culture is rarely performed in routine clinical practice today, though it may still be used in specialized circumstances, such as cases of suspected sexual abuse, where the highest specificity is required, or for antimicrobial susceptibility testing in research settings. Antibody detection through serologic testing measures the host's immune response to chlamydial infection, rather than detecting the organism itself. While this can be useful in some situations, serologic testing has very limited value for diagnosing urogenital chlamydial infections in adults. The fundamental problem is that serology cannot differentiate between current active infection and past resolved infection. Additionally, many people have been exposed to chlamydia at some point and have antibodies, even if they're not currently infected. For these reasons, serology is not recommended for routine diagnosis of urogenital infections. However, serologic testing can be useful in diagnosing lymphogranuloma venereum and in epidemiological studies. For treating Chlamydia trachomatis urogenital infections, we have two primary antibiotic options, doxycycline and azithromycin. Both are highly effective, but they have different advantages that make them suitable for different clinical situations. Doxycycline has excellent efficacy, with cure rates exceeding 95%. Doxycycline works by inhibiting bacterial protein synthesis. Because it penetrates well into cells where chlamydia reside, it's highly effective. The main disadvantage is that it requires a week-long course and twice-daily dosing, which can affect patient adherence. Additionally, doxycycline is contraindicated in pregnant women because tetracyclines can affect fetal bone and tooth development. Azithromycin offers a major practical advantage. It can be given as a single 1-gram oral dose. This directly observed single-dose therapy eliminates concerns about adherence and ensures that patients complete their treatment. Azithromycin also works by inhibiting bacterial protein synthesis. It concentrates in tissues and has a long half-life, providing sustained antibacterial activity even after a single dose. This single-dose regimen makes azithromycin particularly valuable in public health settings, for partner treatment, and in situations where follow-up is uncertain. Azithromycin is also safe in pregnancy, making it the preferred option for pregnant women with chlamydial infection. Comprehensive sex education is fundamental. Young people need accurate information about sexually transmitted infections, how they're transmitted, and the importance of testing. Health education should also address the reality that many chlamydial infections, particularly in women, are asymptomatic, emphasizing that the absence of symptoms doesn't mean absence of infection. Partner notification and treatment is critical. When someone is diagnosed with chlamydia, all sexual partners from the preceding 60 days should be notified, tested, and treated, ideally before their own test results return, to prevent reinfection of the index patient. Unfortunately, despite extensive research, no vaccine for chlamydia is currently available.